Thanks, Nikos, for the introduction. So in the next 20 or so minutes, I'll try and be slick to allow for Professor Flint's time. We'll talk about the indications for liver and kidney transplantation in children, particularly focus on combined liver and kidney transplantation in patients who have metabolic conditions. I'll present one of the patients from the medical side, and I'll leave all the interesting surgical bits for the complex surgical session later this afternoon. But the main aim of this talk is really to show how can we play and win as a team, because we do not want to find ourselves in a situation when we have a lot of experts in the field and wonder how do we play and maybe win as a team. We want to be more be like an orchestra where we can think the same, breathe, and feel as one to deliver these complex transplants. So most of us in this room, and I know delegates online, can find ourselves with generation we belong here, but our patients are those ones coming from Generation Z, and now even more Generation Alpha. And these are some of the characteristics of our patients, so I think some of us need to catch up with them sooner rather than later. So in pediatric renal transplantation, the major advance 20, 30 years ago was that lung hypoplasia is not a problem anymore. In the past, children with congenital anomalies of kidneys and urinary tracts due to the pulmonary hypoplasia, secondary to oligohydramnios or anhydramnios, did not survive outside the neonatal period. But now it is not uncommon that a couple of months later after they birth, we get a phone call from the neonatologist and saying, well, they're off the ventilator, their lungs are actually fine, but the creatinine is 300. So Malcolm Coulthard, who's a consultant pediatric nephrologist from Newcastle, has actually warned us about this in his paper from 21 years ago now, when he was saying that the children who reach end-stage kidney disease in the first 2 years of life actually do not have that bad outcome, and they do survive. We made advances in infant dialysis. We can sort out the lack of the vascular access. That's one of Nikos's future talks. We talked a little bit about the previous symposia about the sensitization, but most importantly, there are new indications for kidney transplantation. Those are the children who have end-stage kidney disease since infancy, who might need multiple kidney transplants or multi-solid organ transplants. And all of that, we as a team have to deliver in the crucial time of their lives, in the childhood, because that is the time when we all grow, when we get educated, and when we actually form our social context. So quite an important period in our lives. This is a very old and very boring graph of the causes for the end-stage kidney disease. Of course, 40 to 50% will go into the congenital anomalies, but we are now starting to depict who are these others. And that includes some metabolic patients with methylmalonic acidemia or primary hyperoxaluria type 1, some of the complex ones, for example, children with Schimke's immunoosseous dysplasia. We've recently done one at Great Ormond Street Hospital, and colleagues at Stanford as well and Pittsburgh have done a couple of those as well. It is not uncommon that there are children who need multiple solid organ transplants and not only liver and kidney. So what would be the indications for liver and kidney transplant? Roughly speaking, they can be grouped into 3 groups. The first one are those children who have end-stage liver failure and then concomitant renal involvement, any conditions which lead to that. The second one, which I will focus on, is the isolated functional liver defect in systemic diseases. And the third and rarest one would be the secondary renal failure after the liver transplant. We might not see that now, but now when the liver surgeons are doing liver transplantation in much smaller children, it might be that even in the childhood, we will be seeing the children with chronic kidney disease secondary to CNI toxicity. This is a list of some of the conditions who would be part of the first group, some ciliopathies, recessive type of polycystic kidney disease, particularly the phenotypically aggressive one. This is the perinatal and neonatal onset, glomerulosclerosis, which gets associated with type 1A glycogen storage disorder, on MPGN, which we have seen with alpha-1 antitrypsin deficiency, children with Alagille syndrome, biliary atresia. Those children who have the metabolic condition, we often talk about primary hyperoxaluria type 1. And the usual, up until recently, recommendation was that the liver transplant should happen when the child is not below the CKD stage 3B in order to avoid the systemic oxalosis. The recommendations for pre and post-transplant continuous venous hemofiltration until we get below the saturation level of oxalate, which is less than 30 micromoles per liter. However, in some countries, since 2020, lumasiran has now been licensed as a drug, which reduces the oxalate production. We need to be aware that this drug is not available or licensed to be used in many other countries. The second one is the methylmalonic aciduria. Children with MMA have improved overall survival, so they are now coming as transplant candidates. Transplantation for these children is not curative, it's therapeutic. And there is still debate and uncertainty whether combined liver and kidney transplantation is favorable than sequential liver and kidney transplants. Those children who have GFR less than 50 at the time when they are assessed for any transplant are considered to be candidates for combined liver and kidney transplants. And this is the protocol from the Stanford who has done the highest number of these patients. In the past, complement hemolytic uretic syndrome or atypical HUS used to be an indication, but now with eculizumab is not. And as I said, in the third group, it's either hepatorenal syndrome or CNI nephrotoxicity. So what are the outcomes of liver and kidney transplantation in children? There are numerous reports in the last 10 years reporting on excellent patient survival and excellent liver and kidney allograft survival. And what all of these papers have commented on, and conclusion which we can draw, is that there is an immunological advantage of doing combined liver and kidney transplant or getting both organs from the same donor. Long-term survival of children who have combined solid organ transplants is similar to the isolated liver or kidney transplant as reported in the literature. No doubt, they come with surgical complexity, and with careful selection of patients, excellent outcomes can be achieved. These surgeries are rare. Worldwide, there's anywhere between 10 to 30 combined liver and kidney transplants in children. And more recently, we are starting to learn about the long-term renal outcome in the patients with MMA, which is now being reported in adolescents in the adults. So we expect in the next 1 or 2 decades to get a lot more information on these children. This graph is a paper from 10 years ago. The patient survival over 10 years, you can see the top line, which is the blue one, combined liver and kidney transplant, has an excellent patient survival, better than the liver or the transplant, isolated liver or kidney transplants. And the graph on the right shows the graft survival split for isolated liver and kidney, and also in those who had combined liver and kidney, and looking into the liver graft survival and kidney. So overall, looking very good. Now, the inborn errors of metabolism, or metabolic conditions as we call them, are rare. They are genetic conditions, and it is only that the increased awareness of the presentation of these conditions and improved diagnostics which have actually increased the incidence of these patients. They are the patients who have fragile health at all times. They can have rapid metabolic deterioration with any minor illness or any intervention, and that includes any surgery. Now think about the combined liver and kidney transplantation, complexity of that, and then add on top of that metabolic frailty. The decompensation can affect the liver, pancreas, and heart, and you can just imagine decompensation of these organs. Any one of them can lead to death. These children often have developmental delays and faltering growths. So for primary hyperoxaluria type 1, the enzyme deficiency is secondary to the genetic variant in the AGXT gene. That mutation leads to systemic oxalosis, which is basically a deposition of calcium oxalate crystals in organs and in tissues. Mainly affects the kidneys, and it's said that in the infant onset of this condition, 50% of children at the age of 15 will have end-stage kidney disease. Some of the phenotypes are successfully treated with pyridoxine replacement or an early liver transplantation. As I mentioned, lumasiran has been approved 3 years ago. However, in a lot of countries, it is not available. And therefore, if the patient has end-stage kidney disease, liver should be transplanted first, and then a kidney, ideally after the 6 months. When I ask colleagues in France who have a huge experience in transplanting this patient, why 6 months? Because we would anticipate that the child would be on dialysis between the liver transplant and the kidney transplant. It was anticipated that that would be the period which would allow sufficient oxalate excretion or removal through the hemodialysis when we have stopped actually the hyperproduction of the oxalate because we have given the healthy liver. If you are opting for the simultaneous liver and kidney transplant in these patients, which is organs coming from deceased donors, we do need to consider CVVH intraoperatively. In our center, in our experience, surgeries are done at King's, and we advise CVVH for 48 hours at least. Some centers continue CVVH for 1 week, such as colleagues in France. No doubt, all of these patients need personalized protocols, depending on the time that they've needed on dialysis and so on. So the outcome of the liver-only transplantation in inborn errors of metabolism is actually not that bad. This is in pediatric population, where we have a good patient survival at 10 years of 80% and allograft survival of 67%. And 20 years later, survival of the liver 70% is considered as an excellent outcome. The patients with MMA are slightly different. So this is a rare autosomal recessive disorder. And we must remember that liver is not the only one that makes the enzyme. About 18% of the MMA activity comes from the kidney. They present in infancy with metabolic acidosis, developmental delay, and failure to thrive. They are known to have renal diseases and also neurological complications, for example, the basal ganglia strokes. Prevalence of end-stage kidney disease can vary between 20 to 60%, because it's a rare condition, reports are just coming through. So in the next decade or so, we'll probably learn more. Preemptive liver transplantation is the gold standard for these patients because it might prevent them from needing the kidney transplant later on. It does lead to 95% reduction in methylmalonic acid levels. An early combined liver and kidney transplantation is indicated in the presence of chronic kidney disease. We must remember that this is not a cure, and it's only therapeutic treatment. So how do we choose whether a child with MMA will need a kidney or a liver or combined one? There are various transplantation options, and this needs to be patient-tailored and needs to fit in within the personalized medicine. So we are moving away from the isolated kidney transplantation for these children and would only consider these as patients who have limited life expectancy or limited quality of life, and we can debate for a long time what does the limited quality of life mean. Because remember, it's only 18% of the MMA that is made in the kidney. We still have the liver that makes majority of the enzyme. Isolated liver transplantation would be great for children who either present with progressive developmental delay, neurological deterioration, but have preserved kidney function, because that might prevent them needing a kidney transplant in the future. Or combined liver and kidney transplantation if they present with a GFR which is less than 50. Now, what's really interesting is putting these children on a waiting list is very challenging, and as us and colleagues from Evelina know, the waiting times are long because they are not a priority. They have normal appearance of the liver and normal liver function tests. There's no portal hypertension, and therefore they are not priority when the organs are being allocated for the very good reasons. It's a complex management of the systemic disease. How can we protocolize this? And each child with different ages have different genotypes or phenotypes associated. So it's an individualized and personalized medicine that works for them. They have excellent outcomes. This was an old paper from 8 years ago, and the mean follow-up at that time was 3.5 years with an excellent patient survival and only one liver allograft loss due to the common or well-associated risk. We move on to the immunosuppression. How do we immunosuppress these children? It really is center-dependent. There is no consensus, and any one of these options can be recommended. We use basiliximab at induction, and then CNIs, tacrolimus, and MMF and prednisolone. In Germany and in France, for example, they use cyclosporine instead of the tacrolimus, MMF, and prednisolone. There was a trial which looked into the use of everolimus and low dose of CNI. The study was discontinued because of the high risk of PTLD and infections. This was probably the landmark paper which was published by the colleagues from the Stanford on the first 14 patients who have either had a liver or a liver kidney transplant. Out of the 14 children with MMA, they have had 8 children who had combined liver and kidney transplant. And if you only look into the age group, you will see that the children who had a liver transplant only were less than 2 years of age. Only one child was 3 years of age. And everybody else who had combined liver and kidney needed both organs. They measured the serum MMA levels 1 and 4 months post-transplant, and you can see significantly reduced and decreased in the levels in the children who had combined liver and kidney transplant. Looking into the neurological outcomes, those who had a liver transplant, 3 out of 5 gained some motor skills, and there were no neurological deteriorations, which was quite successful. And those who had a liver and kidneys, so longer surgeries, longer general anesthetic, more complexities, they have maintained at least their previous level with no further neurological deterioration. And this is just a little bit in more detail, showing that there is a significant number of patients who have increased and gained their fine and gross motor skills after the transplant. So there is an overall patient benefit with decreased frequency of hospitalization, liberalization of diet, some weight gain, but what about improved quality of life? So this is the only one patient that I will present, medical side of it, because it will be presented in more detail later on in a complex surgical session. This was a 4-year-old boy who was referred to us with genetically confirmed methylmalonic aciduria and Williams syndrome, and also had a single renal dysplasia, single kidney, which was dysplastic. He was referred to our London MMA transplant working group, and this really felt like trying to get the English football team to learn how to play as a team and win the World Cup. So we had all the experts that we could. From about 4 hospitals, we had metabolic experts, endocrine experts, there was renal experts, renal transplant and hepatobiliary surgeons, 2 sets of anesthetists, cardiologists, radiologists, intensivists. Clinical nurse specialists, we had 2 sets of coordinators, one for the liver transplantation, one for the kidney transplantation. 2 sets of dietitians to manage the renal end-stage disease and the metabolic ones. Pharmacists, and of course, place specialists, social workers, and psychologists. We must never forget them because the support that these families need is humongous. There were 3 hospitals in London and 1 which was local. So in April 2021, this child had a combined liver and kidney transplant, deceased donor organs. His weight was 12.5 kilograms, and I believe today it remains the smallest child when it comes to the weight. I'll try to remember the height, Steve, of this child. But liver was implanted first, kidney followed. It was a 10-hour-long surgery, and remember, this is the patient with MMA. Any minor illness or any minor disturbance can actually make them crash. The way how we facilitated this 10-hour-long surgery is that the hepatobiliary anesthetist was on an open line with the metabolic team, and this was metabolic consultant. But we've done all of this, and then they couldn't close the abdomen. So you'll hear about that. So this is how the patient looked when it came to the PICU. This was a courtesy by the Nikos, I think. With all this surgery, the surgeons have managed to preserve the gastrostomy that the patient had. For me, this was unbelievable. He came to the ITU. He was intubated, ventilated. We did manage to achieve metabolic stability, but this child still remains at risk of basal ganglia stroke, even post-operatively. The immunosuppression, we debated, less for isolated liver, but then kidneys need more, and we managed to find some common ground. He had basiliximab, which was given after the liver was implanted, then steroids, MMF, and TAC. Fluid requirements, Nadine talked about how difficult it can be. We had here metabolic requirement, renal requirement, liver, and the endocrine, which inotrope to use. I left it all to the anesthetist. The liver team loves adrenaline. The renal transplant team hates adrenaline. So we've kind of went with hepatobiliary surgeons, and I won't talk more about that and use a bit of adrenaline. But when all these people gather, and everybody will come, because this doesn't happen every day, who leads the team? Because you can imagine the human factors, if we incorporate human factors here a little bit, this is a very stressful situation for every single health professional who was involved, every nurse, every coordinator, every consultant. And leading the team needs to be the intensivist, because he needs to orchestrate nicely, all of us. I will not spend a lot of time on this. I've just put something on place which is widely accepted as a perioperative management for the isolated renal transplant and the one for the liver transplant. There are some similarities, but there are also big differences in what they use. So we had to kind of join that together and come up with something which would keep the patient metabolically stable. So this is how the abdomen looked when Nikos finished implanting. You can see the healthy liver, which is on the in the right upper quadrant. There's some bowels in and omentum, and somewhere there, Nikos has managed to implant the kidney. This patient underwent 7 weeks later rectal muscle fascia implantation, and this is what his abdomen looked a couple of months after that with preserved gastrostomy. George has mentioned a little bit of the 3D printing. We use it now for the renovascular patients, so this is one of our renovascular patients. We have used it in the past, led by the Guy's team, the 3D printing. But it doesn't work for deceased donor organs. When you're doing combined liver and kidney, you can prep the abdomen, but you don't know what is the size of the organs that you will get. And although I believe we agree that we will ask for the left lateral segment of the liver, hepatobiliary surgeon decided that the liver was very good, let's just implant the left lateral segment. So the first 6 months, he was inpatient for 2 months and had 2 organs and 1 tissue transplanted. A lot more surgical details will follow. Good function of both allografts. He was maintained on tacrolimus and MMF, and 6 months after the transplant, when he was at home, he had some earache, so he was given amoxicillin. He then developed vomiting and diarrhea, so just remember he's got a metabolic condition for about 3 days, and the emergency feeds that these patients usually get put on did not lead to any improvement. So he went to his local hospital with a creatinine of 310, previously based on about 60 to 70, and grossly elevated liver function test. So if you are a doctor seeing this patient in your A&E and you get these results, which team would you call first? Will you call the renal transplant team or the liver transplant team? Who would call liver people first? I'll call liver, right? Yeah. Whoever you call, if you have good communication between the teams, and planning of these transplants pre, intra, and post-operative takes a lot of months. So what you're dealing with is the sick metabolic patients with 2 transplanted organs, endocrine and metabolic conditions who's immunosuppressed. But the management for these patients is really the same. It's the airway, it's the breathing and circulation, and D, don't ever forget the glucose. The IV fluids that you want to use for maintenance will require metabolic input. He was inpatient only for 1 week in his local hospital, and for the purposes of this talk, I calculated there were 28 healthcare professionals who were involved at any point during that week from 9 specialties in 4 hospitals between England and Wales. But he was made better because everybody worked as a team. So back in 2018, we contacted Stanford when we were discussing setting up a working group and actually giving these children an option to be assessed as transplant candidates. The reason why we asked the Stanford colleagues to come and talk to us about their experience is that we did not want to trip over the same rock because we knew that this will be a difficult road to go. We had many experts, so we were really lucky, but we had to build a team. We never ever doubted that we will have challenges, but it's very rewarding when you see your patients getting better. There are still some things that we are asking ourselves. One is, how do we maintain the skills in managing complex patients with rare conditions? Should we actually do this for such a small number of patients? But if they are surviving their initial conditions, why not? So in the last couple of minutes of this talk, some learning and recommendations, and this was recently published in Pediatric Nephrology, so I now formally and publicly thank Professor Joseph Flynn. We have published the protocol that we use for this patient, and it is based on the same principle. We hope that it can be applied. to any other patients because it is very detailed in the preoperative, perioperative, and postoperative management. Very detailed planning is really important because if we don't do that, we will fail to plan. The metabolic stability before you go into the surgery and anesthetize patient is really, really important. Therefore, the involvement of the multidisciplinary team from the time of the transplant assessment onwards is really necessary. If the patient have metabolic instability, it should not undergo a surgery. You must not proceed with that. If there is a metabolic stability and we are waiting for the organs to come maybe from a distant part of the country, we agree that a 4-hourly blood gas check to ensure that that metabolic stability persists is really important. Availability of the senior metabolic, renal, and liver anesthetic teams is necessary for these patients, and obviously holistic approach for managing them. You won't be able to do this in a center which has experience in the MMA because apart from maybe a couple of centers which have had some experience, there aren't centers. But if your surgeon, anesthetist, nephrologist, hepatologist are experienced in doing high complex cases, this might be a program that you might want to consider. There's nothing on the quality of life. These children, and if you look for the kidney-only, quality of life in kidney-only transplant recipients, out of 366 studies, only 8 looked into the quality of life. So we have just completed 3 weeks ago in the UK a national study which was running over the past 2 years. It included 92 patients who had a multi-solid organ transplant during a 20-year period. And you can see vast majority are those who had liver and kidney, but good number of patients who had a heart and kidney transplant. And what we've added on is the quality of life in these patients. And to our knowledge, this will be the first published study which correlates the clinical outcomes with the quality of life in children who undergo this type of surgery. So to summarize, there is a change in indications for combined liver and kidney transplants in the childhood, good clinical outcomes which are comparable to children with isolated liver or kidney transplant. It does take a village to raise a child, and it does take a multidisciplinary team to facilitate this transplantation. It remains a high-risk surgery for patients with inborn errors of metabolism, but it can be successfully achievable and if done in the center's experience in doing complex surgeries. And it's personalized protocols that work the best for these patients. Thank you.
Very much, Jelena. Great talk and a lot of great work as well. Questions from the audience? Yes, thank you.
Hi, Alan. Can I just ask, do you have any experience yet of working patients up who are on lumasiran for transplant? Because we have a patient in Glasgow who parents have essentially, a PH1 patient, sorry, who parents have kind of declined liver and they want to just continue with lumasiran, which makes me a little bit twitchy.
With the?
Sorry?
To continue with, sorry, I couldn't hear.
Lumasiran, sorry, for PH1. Have you, in Gosh or anyone else in the room, I guess, has anyone else?
Yeah.
I know there's been there's a French case series that was published of some patients that have.
Yes, we do have. We actually have a family who has 2 children, and the daughter, who is probably now about 13, had for PH1 had a liver transplant first, then the kidney, and now needed to have a second liver transplant. At the time when she was having her second liver transplant, her mother gave birth to a second child who had a PH1, and I believe it was the first neonate that William Van Hoff facilitated treatment with lumasiran. He must be now probably 4 years of age and is not coming up for transplant assessment. So that is the only one case that I can remember, but maybe Zainab and Steve can comment more if they have any more patients. But yeah, we have actually a family with 2 children who underwent different pathways.
Thank you. Thank you very much, Jelena. Oh, one more question, sorry.
Just in terms of workup for a child with MMA, which GFR would you take? Because these children are really, really malnourished. So would you always do a formal EDTA GFR?
Yes, we do. And metabolic team, actually, they're part of their monitoring, at least at GOS, and I know at Evelina as well with Roshi, they do annual GFRs, formal GFRs, and that's what we monitor for them. So never estimated. You're absolutely right.
Thank you.